you're resetting the metabolic set point in patients from a weight standpoint when you have these bariatric surgeries. That's not the case with these GLP-1 medications. And so as soon as patients either lose access, can't afford it, coverage gets dropped with insurance, patients regain weight.
GLP-1 medications are exploding in popularity right now, but bariatric surgery is still the most effective treatment we have for obesity. And yet, only 1% of ideal candidates are actually getting the surgery. We have so many incredible tools in our toolbox to help with the management of obesity. But as a clinician, how do you decide between the two? And what should you do as a primary care clinician when a bariatric surgery patient walks into your exam room? Welcome back to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. I'm your host, Colleen Sloan. I'm a PA and a dietitian. And actually, when I was a brand new baby dietitian, I spent about a year working in a bariatric clinic. And this was back when obesity medications like the GLP-1s weren't even part of the conversation. So watching how quickly this field has evolved has been really fascinating for me, which is why I'm super excited for us to learn from Kate Foose today. She's a surgical residency trained PA from Yale Newark Hospital and a board-certified specialist in obesity and weight management. And she's got more than 13 years of experience in bariatric surgery and obesity medicine. So in this episode, she's helping us understand when bariatric surgery may be the better option, how GLP-1 medications and surgery can work together, and what every primary care clinician should know when caring for post-bariatric patients. So get comfy or drive safe and enjoy my conversation with Kate. Kate, thank you so much for reaching out and suggesting this incredible topic for the podcast. I'm really excited to chat with you. So welcome to the show.
Thank you for having me, Colleen. I really appreciate it.
We're really going to get into the kind of the psychological and emotional impacts of weight loss in general, but specifically bariatric surgery. And so I'm really interested in understanding, why does hitting a weight goal not always translate into better emotional health?
I love this question because so often we have patients coming into our clinic that are very number focused on the scale, and they've also tried every diet and lifestyle hack there is. They're chasing that number. And so when I ask patients, why now? Why are you here? What's your goal? And they give me a number, I try to redirect them because I ask them, what happens if you hit that goal? Are you done trying? Is your life, is that it? No, it's just it just opens up a new world for them. But more importantly, the question is, what happens if you don't hit that number? And where does the number even come from? Sometimes it's so arbitrary. It's oh yeah, I was one time in high school, that way. And you're like, what are we chasing? So I try to redirect them to a why, in terms of longevity, quality metrics, to really psychologically put them in the right headspace. With a bariatric patient or any patient on a weight loss journey, because I also see, medical weight loss patients, the psychological part is the biggest barrier for patients. So if we're talking about bariatric patients, they think it's what to eat. It's the nutritional side, right? With your perspective, it's what do I eat? How much do I need to eat? But they don't realize that mentally that's the biggest journey for them after surgery. And so that's why I want them focused on other things other than the number, because they can become all or nothing headspace, right? Or they'll think they're a failure if they don't hit that number. So I don't define their success by that number, but yeah, always direct to their underlying why. That's more non-scale victory based.
I love that. And we have a mutual colleague, Nina Crowley, who's the queen of promoting non-scale victories. And she's been on the podcast. She was also a speaker in the obesity medicine nutrition course, kind of my flagship course that I teach clinicians, walk them through how to help patients lose weight through nutrition and medication. And I also had a dietitian. She did the bariatric portion of that course. And she has a technique, or strategy, I guess you would call it, for patients who are very numbers focused, especially that goal weight, which I love that you said it's kind of arbitrary. Where did it come from, And so she actually has them write down that number on a big sheet of paper, old school lined paper. Write that number. It's 180, 210, whatever the number is. Write that number on the top. And then underneath it, write down all the things that you think you'll be able to do or want to be able to do when you become that weight. And I love this exercise because what she does is she then tears off that top number. And then now we are solely focusing on getting you to feel confident in a wedding dress or wear a bikini and feel sexy, or, your A1C is down below, 6, who knows what it is, then you can really focus on those tangible things. And I really like something that you said, that they can often feel like a failure if they don't reach that goal weight. And so, how do we help our patients kind of reframe that mindset, but also educate them that there is something to be learned, and success is through the journey? How do we tell our patients that?
Yes. I always say it's progress over perfection. We're talking, most of my patients are middle aged women. They're trying to be everything to everyone all the time. They're trying to be perfect. They put themselves last. And it's exhausting, honestly. And so, if they're not by the book doing it perfectly, then they have automatically put themselves into this bucket of failure. It's never going to work for me. And so, I always reframe that headspace around it's about progress. Because if they fall into the all or nothing trap, what my patients will say is, well, I'll just wait until there's that perfect time. It's really stressful right now. My life is really busy. I'll just wait until after the season of life ends and I'll just restart. It's like, no, don't waste that time. You have to change your headspace and say, what can I do today? What can I do tomorrow? And let's reset some micro goals, because those micro goals done consistently will turn into the foundation of healthy habits. And those healthy habits will stack on top of each other. And that's when you see the progress.
All right, I want to move into sort of your bread and butter, which is the bariatric patient. Let's back up and imagine that we're primary care clinicians. And I'd love to hear from your perspective. What do you think primary care clinicians really underestimate about caring for patients post bariatric surgery?
I had a surgeon explain it this way. Once you've had bariatric surgery and that surgeon has operated on them, that patient is married to the bariatric surgeon. You're in a long-term relationship. This is a lifelong commitment to your bariatric team, because what primary care providers need to understand is this is often an irreversible, procedure that they've had. They are inheriting malabsorption, restriction. And so they need to be on lifelong vitamins because there is a really strong long-term risk of vitamin and mineral deficiencies. So that's something that they need to be followed very closely with the bariatric team for life. Usually after the first year, we can space our patients out. We can see them on an annual basis if everything is looking great. But oftentimes I'm seeing patients at least every 6 months with our own bariatric panel of labs, checking our own vitamins, minerals, nutrients, hormones, alongside what their primary care provider is doing. So I like to tell patients we also like to be the centralizer of care as well. Our patients are seeing a lot of different providers in different specialties. We're not replacing primary care. We're definitely working alongside them in a multidisciplinary team. But our patients are maybe seeing GI and endocrinology and neuro and ortho and rheum and all of these other specialists. And so we like to be involved, since some of these things do overlap a lot with obesity care and bariatric surgery. So,
Can we support our patients in choosing to continue lifelong relationship with their bariatric team? Because I can imagine some pushback from a patient, especially they're like, "Why? I had the surgery 3 years ago. Like, I'm either doing fine or I'm just here because I need your help losing weight, primary care provider." So how do we encourage them or gently nudge them to return to their bariatric team?
I think just educating them that whenever you've had bariatric surgery, you always need to be under the care of a bariatric team. If it's access to a team or they don't have their surgeon anymore and they relocated, what would be helpful from a primary care provider standpoint is if they have their own referral network, if they know someone. So as a PCP, if you're listening, see who's around you, understand the bariatric teams that are local to you. They're going to be very multidisciplinary. They're going to have integration with psychology, registered dietitians. They're also going to have maybe physical therapists on staff or in reference to, and APPs and other providers who can help with the medical and surgical side. So, those are specialists in obesity care. And when you are aware of the clinics and providers local to you, that's the best service you can give to those patients, to re-educate them that this is not just you check the box, you had surgery, you check the box, you only take your vitamins for the first year. They need to be taking their vitamins for the rest of their life. And patches are not okay for vitamins while we're on the topic. Flintstone gummies, chewables, like none of that stuff is good. They need to be on ASMBS backed vitamins. Okay, so that's one thing you want to educate them on. And also, you're not responsible for having to know all the vitamins. I know it's confusing. So that's why being able to say, well, your bariatric team can help you with that, with knowing which ones to take and knowing which labs to be followed up on. Okay, because they do need more detailed lab work than just an annual exam's worth of primary care labs. And so, again, nothing you need to educate them on, but just something to coordinate care. That's very important for patients.
Hey, real quick, if you want to better understand topics like bariatric surgery, nutrition after surgery, vitamin supplementation, and helping patients navigate weight loss with medications, I cover all of that inside my obesity medicine nutrition course. It's a comprehensive training for clinicians covering all the pillars of obesity care. And I just added a new module on oral Wegovy. You can check it out at examroomnutrition.com/course. All right, let's get back to the episode. Agree. And I'm really glad that you actually touched a little bit on the different types of vitamins, because you are right. The bariatric vitamins are very different, very specific for the needs of a bariatric patient. I think that's a helpful kind of reframe if a patient is asking you like, oh, well, what kind of vitamins? That's your doorway in to say, this is a really complex, special case that you need to work with a specialist. It's just beyond my scope of practice. And I think that's really just good medicine.
Well, and if you need just a blanket thing to say, bariatric multivitamin with iron and calcium. And what you're going to see in primary care is certain things popping up on a basic panel of labs, like iron deficiency, anemia, super common in some of these patients who have the restriction and malabsorption. So there is a lot of overlap. Vitamin D deficiencies, we get that in the calcium that we're giving our patients. So if you feel like you're running into a lot of these issues and you're referring to hematology because their iron and anemia is in the gutter, there could be, yes, obviously that happening, but there could be copper deficiencies and other things that just warrant tighter monitoring, surveillance, and management. And that's the other thing is, as a bariatric team, when we're ordering these panels of labs, we are the ones repleting and supplementing. So it's good for us to know when we talk to our patients what supplements they're on, because usually we'll hear, my primary has me on a vitamin D, a B12, like all this stuff, which together with their bariatric vitamins, is important for us to know ranges. And also one pitch for vitamin D, if you're giving a vitamin D supplement, just make sure that you're also including that on follow-up primary labs to make sure it's a fat soluble vitamin and it can accumulate in the body's tissue. So I have seen patients who, whether they followed up with their primary or not, are on weekly vitamin D, and their vitamin D levels are exceptionally high. So again, tight monitoring and refer to bariatric teams if you're ever unsure is super safe call.
Right. I want to move into a very hot topic right now, and that is talking about GLP-1s in bariatric care, kind of with this lens. And I just recently did a presentation for the AAPA All in the Family Medical Conference in Vegas. And I would talk about the treatment landscapes. We've got lifestyle, we've got medication, and people forget we have bariatric surgery still, right? Like it's kind of like the forgotten treatment. I think the statistic is like 1% of patients who would qualify for surgery actually get it. And that's astounding because we have great outcomes with bariatric surgery. And I mean, we could go into a whole podcast episode on the stigma behind it.
Let's do it.
I mean, geez, there's so many reasons why people don't want to or are scared to get bariatric surgery. So I would love, from your perspective, are GLP-1s competing with bariatric surgery? Can they be complementary? And kind of how do you frame this conversation around the options?
I mean, there's no question that surgery has taken a hit because of the medications, but they're absolutely complementary. If you look at obesity as a chronic and relapsing disease, and also with almost like cancer treatment modality and treatment plan, we use GLP medications neoadjuvantly, right? Before they come into surgery, especially with patients higher BMIs, because it nutritionally optimizes them, makes them a little bit more medically, they can lose weight before surgery. So it helps increase the safety leading up to surgery for that additional weight loss. But to your point, Colleen, bariatric surgery is a metabolic surgery, and it is the strongest tool that we have. So yes, you are right. Foundationally, we do the pillars of diet, lifestyle, exercise. Pharmacotherapy is definitely next on that treatment plan. And then surgery. It is an extremely safe surgery. It is safer. If you look at the data on mortality after a gallbladder, a cholecystectomy, and bariatric surgery, it is safer to undergo bariatric surgery. So there is a lot of misconception of what that's like. In the past, they were doing open surgeries. This is all laparoscopic, robotic. Turnaround time is great. Patients are up and at it right away. So this is a very safe surgery and is our strongest tool. So just touching upon that real quick, when we compare apples to apples, looking at total weight loss, you're resetting the metabolic set point in patients from a weight standpoint when you have these bariatric surgeries. That's not the case with these GLP-1 medications or dual medications, because they are providing the exogenous hormone, right? And so as soon as patients either lose access, can't afford it, coverage gets dropped with insurance, patients regain weight. And that's not to say patients won't regain weight after bariatric surgery, but bariatric surgery is a metabolic procedure. And so, yes, if and when patients do regain weight after surgery, then we pull the medications back in again. So typically that timeline is we'll put them on beforehand, stop for surgery. We let surgery run its metabolic course. We don't have a standardized protocol, but clinically for me, I'll typically wait till at least 9 months out from surgery in order to see if they really have significant weight plateaus and regain years down the road. Then we put that back in again. But we're talking with the SADI and Switch are our two most malabsorptive procedures, and they can help patients lose 35 to 38% total weight loss. Okay. Even the bypass is 25%, and the sleeve is around 20% total weight loss relative to tirzepatide. That's going to get you 15 to 20%, but real life, it might be a little bit lower than that. Semaglutide, that's around 10 to 14%. Again, real life numbers are on the lower range of that. So they're great adjunctive before and after, but your strongest tool and your safest tools are always bariatric surgery. So as a PCP, if you have a patient who qualifies, who has overweight, a BMI of 27 and comorbidities, or a BMI of 30, they're a great candidate for medications. But if you start getting a patient in the BMIs of 30, upwards of 35 plus, now we're kind of entering in that surgery realm where that might be a great opportunity to refer them to a bariatric team so that they can at least offer that conversation, to compare what treatment option and let the patient be a part of that conversation. But real quick, patients might be scared of surgery because they're hearing it from family and friends, and there's a lot of misinformation about it's so dangerous, and you hear the stuff on the news, and it's a lot of fear mongering. When they're educated on the safety profile and how it could really help put, comorbidities like type 2 diabetes and cardiovascular disease risk and, all of the gains that we look for medications to help fix, but our strongest tool is the bariatric surgery. We're looking at type 2 diabetics getting into remission, coming off their blood pressure meds within the first year after bariatric surgery, improvements in MASLD, so fatty liver disease, right? All of these things you have access to a great tool. So if you're not sure about it, either definitely learn more about it or connect with your local bariatric team.
Yeah.
For your patient's sake.
I totally agree with you. I've actually had numerous friends and family members who have gone through with bariatric surgery, the different options or the different surgery, and have had amazing outcomes. And I think you're right. There's that stigma that for sure fear of surgery and fear of negative outcomes, but also the stigma that it's the easy way out, or like you're cheating because you're just changing the anatomy of your stomach. And how would you reframe that if someone were to say, oh, my wife doesn't want me to get it because it's, the easy way out? What would you say in response to that?
Would first connect them into a community of bariatric patients, because that is really the differentiator. They need that mentorship, because a lot of patients are on social media. So they're in all of these bariatric or weight loss surgery groups, and all they're hearing maybe is like the negative stories that happen. They need to be connected into a community of patients who, are doing the right things, they're compliant with our guidelines, and they're having substantial weight loss success and improvements of their comorbidities. To really say, a lot of patients will say, oh, I wish I just did this 10 years ago because I'm a whole other person. And to be the gatekeeper of that and to just really help augment patients and encourage them to go and explore that as an option. Patients aren't just going to commit to bariatric surgery. Most patients aren't, right? It takes them usually just thinking about it, learning about it, going through the insurance hoops, and it sometimes can take a couple of years. And so we'll see patients in our clinic and we'll treat them medically with the medications until if they stall or they're at the capacity of what the medications can really offer them. But patients with higher BMIs are ideally bariatric surgery candidates, and you should at least broach the topic of that to them in conversation. That hey, bariatric surgery is still your strongest tool, and you can still use the medications before and after. But this might get you, and this is where you can pull the numbers for their goal weight. Is I like to say, where are we now and where is your goal weight and how much percentile in terms of total weight loss do you need to lose to get to your goal weight? And then you can really compare some of those percentages I shared with the bariatric surgery side, right? Some upwards of 20 to 35, almost 40% total weight loss with bariatric surgery. So educating patients on the realistic weight loss outcomes of their options is also a big part of this conversation as well.
Yeah, I want to linger here a little bit because that's my next thing I was curious about is how do you as a PA actually decide between bariatric surgery and GLP-1? Now, I want to go beyond shared decision making because I agree with you and I hope all of my listeners know that that's important. You decide with the patient. There's a lot of outside factors, but I want to get really practical and it's kind of like where you were going. So let's say I have a patient who is 280 pounds and maybe they're like 5'8", 5'9". And so with that patient, kind of walk me through what you were talking about with the percent weight loss expected, how much we think they need to lose weight. Like, work us through what you do with a patient sitting in front of you who's got those numbers.
Okay, so you gave me specific numbers. So of course I'm going to have to look it up. So an ideal body weight for a patient, I think you said 5'9", is 169 pounds. And so if their starting weight is 280, they have 110 pounds that they have to lose. Okay, so that's a total weight loss of about 39.5%. And this is exactly what I calculate in front of patients. Now, this is assuming that their goal weight is going to be the ideal body weight. Sometimes patients don't want to be the 169 and they're very comfortable in the 180s or higher. Okay, so that's the other driver too of where we're going. But yeah, you're looking at almost a 40% total weight loss. And so I'll tell the patients, I'll say, these are your tools. When you are maximizing diet and lifestyle and you're on the maximum dose of these medications, the strongest medications on the market, and you're on them for at least a year or two, because these are what the clinical trials are showing, then yes, you could possibly get up to 22% total weight loss, which is still not going to get you to your goal weight. And maybe I'll clock in or calculate in like what that number actually looks like to them at the 22% because they like the numbers. Okay. So I'm just meeting them where they are. And then I'll say, okay, then part of my conversation is, well, do you know if you have insurance coverage on these medications? Because that is a big driver, regardless of what they want. If they don't have coverage for it, then I have to have the cost conversation and they say, well, that's too cost prohibitive. And then I'm like, okay, well, now we're talking about oral agents and that's really only going to get you maybe 10%, let's say, best case scenario, if you're doing all the things. Now, I also can't predict their responsiveness to these medications. They could be a super responder. They could be an under responder. And so I always say, your strongest tool will always be bariatric surgery. And I usually just leave it there. And I hear what they say. They say, well, I'm open to it. Or, yeah, I know my insurance has coverage to it. Then that's a little bit easier to kind of revisit that. And I'll say, are you open to having a conversation with our surgeons about it to learn more about what options, are available to you from the bariatric surgeries? And to say yes or no. And so, no, I usually dive in a little bit more and I try to understand if there's fear underneath and try to help just, again, very gently, but just re-educate and revisit. And, at some point, again, after a couple of years, they might say, I want to just try everything I can. And they have to get to the point where they're like, okay, enough's enough. I'm sick of this. Because keep in mind, these patients have dieted their whole life. They've tried everything. They've yo-yo diet. They've done every diet and thing. They're done. And they want something that's going to long last so they don't feel like a failure. But that's how I drive that conversation with patients. Now, in terms of the cutoffs and the medical side of things, from a BMI standpoint, how to be candidate for the medical weight loss is a BMI of 27 with comorbidities, high blood pressure, diabetes, sleep apnea, hyperlipidemia, cardiovascular disease, 30 without. And bariatric surgery right now is 35 with comorbidities and 40 without, although there is drive from our national organizations to kind of drop those by 5 BMI points. So that's kind of where I am. I also I also factor too their past medical history. Do they have type 2 diabetes? Do they have fatty liver disease? There's a lot of cardiovascular disease, cirrhosis. Bariatric is a metabolic surgery that can really help put these chronic conditions into remission for patients. And so having that conversation too, aside from the number on the scale, like some patients want improvement in comorbidities to extend their longevity. We're talking about grandparents who want to play with their kids, who want to be around, or they've got really bad osteoarthritic disease and they're dealing with pain, just living their activities of daily living. And so, and some of them want to have like a total knee replacement or hip replacement, but their orthopedic surgeon won't operate on them until they lose weight. And so this could be really how you frame the conversation too, of how the tools will help you get what your goal is, to just live without pain or less pain and to be more ambulatory and functioning, can be a big, not to say selling point, but can speak similar language to what the patients also want, in more alignment with what the patient's goals are.
Have you ever had a scenario where a patient maybe opted out of bariatric surgery? They wanted to go lifestyle and obesity medication route. They lost weight, maybe not enough to where they wanted, but now they do not qualify for bariatric surgery. Is this a case, is this a scenario that happens?
It can. And I think, it's a moving target with insurance companies. I always like to reference the starting BMI, because anytime that we do bariatric surgery, it's always, we're putting that BMI in remission. Our body works against weight loss to kind of go back up. Now, the good thing is about bariatric surgery is it'll help reset that weight set point. So it is really tough, especially if you have a patient who is kind of teetering on that BMI of 30 with what insurance companies are requesting for coverage. But I always start with the starting BMI just to make a strong case for that, because we do want patients to lose weight. A couple of reasons. One is to show that they can commit to diet and lifestyle, because that is required to follow bariatric safe lifestyle after surgery. And also, a couple weeks leading into surgery, we have our patients go on a liver shrink diet. And the intention of that is to shrink the size of the liver to make it surgically easier to navigate in the operating room in their belly. And so, we don't shy away from weight loss leading up to surgery. And I think you just have to advocate for that starting BMI in terms of insurance coverage.
All right. Now, you had mentioned this, but I wanted to make sure we give this the respect that is due, or the information that it is due, because it might be new for maybe some new clinicians or PCPs, that it is okay if a patient has had bariatric surgery to put them on an obesity medication. So what are the indications that you might put someone on a GLP-1 or another medication post-operatively, and when do you do that?
Great question. Yes, they're an adjunctive tool. We use them after surgery often. So the sleeve gastrectomy is one of our most common procedures. It's done almost 60% of the operations that we offer to patients. And so we do see some regain with that long term in our veteran or alumni patients. And that's when I'll see a lot more play with the adding in adjunctive therapies with the GLP-1 medications, for example. So I try not to, I like to give the patients at least that first year, generically speaking, after surgery, to let the metabolic effects really showcase for the patients. So in terms of patterns of weight loss, the most rapid weight loss is going to happen the first 6 months after the bariatric surgery. It's very common for patients to stall at that 6-month mark. And I don't jump into the medications right then, because a lot of that is revisiting some of those diet and lifestyle habits we want to come back to, in terms of, are you eating enough? Okay, patients typically are not eating enough, because if you think of the GLP-1 medications, we're giving them an amplified dose of that fullness, early satiety. They have that restriction. And often when I see patients back years later, I say, when we start this GLP-1 medication, it's like having your bariatric stomach in surgery all over again, fresh out of surgery. You're not thinking about food. The food noise is quiet. Those are things we'll pick up on down the road once we feel like the body has adjusted to the bariatric surgery and the hormones are becoming a little bit better balanced. We'll hear patients say things like, I'm feeling more hungry, or my cravings are coming back, or I have so much food noise and it's scaring me. So the first 6 months, rapid weight loss stalls are common. Usually they're more active. They've gotten to handle their surgery. They're feeling back to life again. And so they just need to eat more food, which again, that's a whole other conversation, but they need to eat enough. They need to be eating at least 1,000, 1,200 calories a day, generically speaking, in order to see the scale move. And so then they'll be on their path, maybe a couple more stalls by 9 months, but by a year or so later, if they're really doing all of the pillars appropriately with eating enough and moving their body and nothing seems to be working, the quality of the food too is important. So working intimately with the RDs, high protein, low carb, high fiber, low glycemic index foods to counter some of those sugar cravings. Yeah, if they're doing everything right and they're saying, it doesn't matter what I do, I just can't stop and it's scaring me. Because again, that fear of regain is like we absolutely will put them on a medication to help with that. Mm-hmm.
Oh my gosh, Kate, you've been a wealth of information. I've just learned so much from you. We could probably chat for hours. So I'm sure my audience will want to have you back on. But if people want to connect with you online, where should we send them?
Thanks so much. Yes. So I have a virtual aftercare program for bariatric patients, but also medical weight loss patients. It's bananabariatrics.com. And if you're a provider, you can find the provider tab at the top. And that's really how to integrate a program like Banana into your practice adjunctively alongside. So that's really good for your patients. If they're thinking about bariatric surgery or they're struggling with overweight or obesity, it really is an umbrella to help educate them, get them back on track, and also engaged and in action in a community of patients. So would love to connect. You'll get all my contact information on there as well. Thanks so much.
We'll absolutely link down to that below. Community is crucial, absolutely for post-bariatric patients, but honestly for all of us. But for the medical weight loss, space, they really need to be in community so they have support and also the guidance from a brilliant PA like Kate. So go check that out down in the show notes. Kate, thank you so much for the gift of your time. I appreciate you being here.
Thanks so much for having me. It's been a pleasure.
All right, now it's time for my nutrition notes. So fun fact, I have nutrition interns rotating with me a few times a year for 4 weeks, and they get an inside look at podcasting. So after this recording, my intern, Patty, and I had a discussion about ideal body weight. So I wanted to leave you with a few thoughts. Now, the concept of ideal body weight actually comes from the Metropolitan Life Insurance height weight tables that were developed in the 1940s to estimate the weight associated with the lowest mortality for a given height and sex. Over time, those tables evolved into predictive formulas that many clinicians still use today, like the Divine formula and the HOMWE method, which is what a lot of registered dietitians use. Now, in the example in the episode, Kate used the Robinson formula, but don't get too hung up on which formula you use. There are plenty of online calculators that can help with that. But in this conversation of ideal body weight, it's also important that we remember that ideal body weight is not always the clinical goal. Most patients with obesity are unlikely to reach a quote ideal body weight, and frankly, they don't need to. And that language can sometimes be really upsetting for patients. Now, organizations like the Obesity Society and the American Association of Clinical Endocrinology emphasize that meaningful health benefits occur with much smaller reductions in weight. In fact, losing just 5 to 10% of total body weight can lead to measurable improvements in things like blood pressure, hemoglobin A1C, and cardiometabolic risk. And as weight loss increases, so do the benefits. 5 to 10% weight loss improves blood pressure and glycemic control. 10 to 15% weight loss may improve conditions like fatty liver disease and obstructive sleep apnea. And losses of 15% or more can lead to even broader metabolic improvements. So when you're talking with patients, I would avoid using the ideal body weight as the target, just like Kate and I had discussed. Frame the conversation around percentage of weight loss and the health outcomes. Your goals should be in alignment with the patient's goals. And remind your patients that progress matters and the skills that they learn throughout this journey can be incredibly beneficial, even if they never reach their ideal body weight. So whether a patient chooses medication, bariatric surgery, or lifestyle therapy, our job as clinicians is not to chase a number on the scale. Our job is to help patients build the behaviors that support their long-term health. Well, thanks so much for carving out some time for nutrition today. I'd love to hear your thoughts on this episode. Shoot me a DM at Exam Room Nutrition, and I will see you next week as we continue to keep our patients healthier, one exam room at a time.